The use of Doppler sonography in obstetrics began in about the 1970s. The word Doppler derives from the Austrian physicist Christian Doppler, and it's defined as the frequency of a wave, which is usually light or sound, for an observer moving relative to its source. Dopplers in OB are sound waves, and they're used during ultrasound of the fetus. They're also commonly used during ultrasound of the placenta and the maternal blood flow. Always the goal in obstetrics is to minimize the exposure of the fetus to ultrasound energy. And in theory, you want to use the lowest energy level for the shortest time. There's a thermal index reported on every ultrasound machine, and it should always be less than 1. That should be able to be found on any ultrasound machine used in obstetric ultrasound. Dopplers and Doppler sonography in obstetrics is a non-invasive way to assess the status of the fetus, as well as the status of placental function and uterine perfusion. There are several different types of Dopplers performed in obstetrics. An umbilical artery Doppler is probably the most frequently used. Umbilical artery Dopplers assess the flow of blood from the fetus to the placenta and mostly establish for the sonographer what placental function is like. As you will recall, in a normal umbilical cord, there is one umbilical vein and there are 2 umbilical arteries. And either artery can be used to assess fetal status. If you find abnormal umbilical artery indices in one umbilical artery, you should always evaluate the other umbilical artery to make sure that you don't have just one abnormal umbilical artery. Umbilical artery Dopplers are assessed throughout the cardiac cycle. We know that during systole and diastole, there should always be forward flow in the umbilical artery. So when assessing an umbilical artery Doppler, you get a waveform that looks like this. The frequency of the waveforms depends on the fetal heart rate, which can actually be measured using this waveform. This peak right here represents peak systolic velocity or peak systolic flow, and this valley represents end diastolic flow. Peak systolic flow, end diastolic flow. And from this peak to this peak measured on the ultrasound machine will give you the fetal heart rate. Some Dopplers in obstetrics can be falsely abnormal if the fetal heart rate is very low, but umbilical artery Doppler is not one of those. So in this waveform, if this is 0 flow here, if this is our baseline, we see that there is systolic flow and diastolic flow throughout the cycle. And this goes through several cardiac cycles. We know that the flow of blood through the placenta increases or becomes less resistant as pregnancy progresses under normal circumstances. So earlier in pregnancy, less diastolic flow is not necessarily abnormal. There are nomograms for what is considered to be normal throughout gestational age. This is a demonstration of a normal umbilical artery waveform. In a situation where a fetus is growth restricted or there's abnormal placental function, what you start to see is a decrease in diastolic flow. And this is abnormal. Again, this is peak systolic flow, and this is end diastolic flow. Systolic and diastolic. And there's much less flow in this image than there was in this image. And what this demonstrates is increased resistance of the placenta, which causes impedance of blood flow from the fetus to the placenta. During cardiac ventricular contraction, systolic flow is usually unchanged. But when diastole occurs with ventricular filling, not as much forward flow occurs. As placental dysfunction worsens, you can actually start to see absent end diastolic flow. And further worsening of placental function can actually demonstrate reversed end diastolic flow. And this demonstrates actual backwards flow of blood through the umbilical artery, in which there should always be forward flow. So to summarize, there should always be forward flow from the uterus to the placenta throughout the cardiac cycle. Increasing placental resistance leads to decreased diastolic flow in the umbilical artery, and further deterioration can lead to absent end diastolic flow and then reversed end diastolic flow. A large amount of ventricular output from the fetus is directed to the placenta through the umbilical arteries. So increased impedance to flow will eventually lead to increased ventricular afterload in the fetus. Especially the right ventricle. Increased ventricular afterload, especially in the right ventricle, will lead to fetal hypoxemia. To accurately measure flow through the umbilical artery, one must obtain a free loop of umbilical cord as close to midway between the fetus and the placenta as possible. If Doppler flow is measured at the fetal end of the umbilical cord, the impedance to flow is going to be the highest. And if it's measured at the placenta end, the impedance will be falsely lowered. So this measurement should be made somewhere on the umbilical cord that's floating freely. And again, under normal circumstances, the umbilical artery is a high flow, low resistance flow that should become lower resistance as pregnancy progresses. So to evaluate these waveforms, there are several mathematical calculations that can be used. So again, I'll draw a normal waveform to demonstrate. There's systole, or systolic flow, there's diastolic flow. So the easiest way to evaluate these waveforms is to look at the systolic to diastolic ratio. And it does just that. You divide systolic flow divided by diastolic flow. And in general, after 30 weeks gestation, anything greater than 3.0 is considered to be abnormal. This is a very, really a very crude measurement, but certainly easy to do and quick to do. However, if you're in a situation where you have absent end diastolic flow, then your diastolic number is going to be 0 and you will not get a result. The caveat to that is that if you have absent end diastolic flow, you are already aware of the fact that you have placental dysfunction, so these numbers aren't quite as important. You can just look at the waveform and tell that there's something wrong. Pulsatility index is measured by calculating systolic flow minus diastolic flow divided by the mean of systolic and diastolic flow. This is a much more difficult calculation for the ultrasound machine to do, and it takes a little bit longer for the ultrasound machine to do it. However, it's more generalizable, and when diastolic flow is 0, you can still get a result because the denominator in this calculation is never going to be 0 unless the fetus does not have a heartbeat. There's always systolic flow. The resistivity index is a third calculation, and that's calculated by taking systolic flow minus diastolic flow divided by systolic flow. Now, there are nomograms for each one of these types of calculations based on gestational age. As I mentioned a minute ago, we know that resistance to flow in the placenta should decrease as or as gestation increases. So if you have a patient that's 35 weeks and their SD ratio is 3, that's normal. If you have a 35-week patient who has an SD ratio of 4.25, that's not normal. But if the patient's 23 weeks gestation, that's actually normal because we know that with the flow through the placenta earlier in gestation is less. So what is the umbilical artery Doppler useful for? This Doppler assessment is most useful in fetuses that are known to be growth restricted, as it can help assess the risk of perinatal morbidity and mortality, and also help with management of these fetuses and planning for delivery. The worse the umbilical artery waveform is, the higher the impedance to blood flow from the umbilical artery to the placenta is, the more compromised the fetus is. And it's actually a very useful tool to prevent perinatal mortality in these pregnancies. It can also be used in other disorders where uteroplacental blood flow might be compromised, such as patients with chronic hypertension, especially of long-standing nature, and those who require medications and are not well controlled. Patients with diabetes, with renal involvement, or any other vasculopathy, as flow to the uterine artery can be affected by this. Patients with sickle cell disease can also have abnormal Dopplers, and Dopplers can be used to assess these situations. The most use, however, is in fetuses with growth restriction, and it's a very useful tool to prevent perinatal mortality.